am so honored to be here. Thank you, Laura and team. My name is Kara Bendle. I am the co-administrative director for the Integrated Program for Young People with Cancer, focusing on connecting patients to not only those psychosocial resources they may need throughout their cancer continuum, but also some of those clinical services that they may need throughout the continuum of care. This is focused on patients ages 15 to 49, so a wide range of things. Really passionate not only about that fertility preservation piece, but also connecting people to our amazing external partners that exist nationally, and then also our internal resources such as a wig boutique or massage. And so really wanting to help be that bridge and that connector piece for patients. My other hat that I wear is I also do fertility preservation program management. And so that's where this conversation also blends into my experience. And I'm really excited to be here. Came into this space actually after witnessing a friend and colleague go through their own cancer journey when we were newly nurses or freshly nurses. And she unfortunately had a relapse and then was treated actually on our cancer unit that we were working on. And I just saw it was like a reckoning of not only thinking about her fertility, which she always had wanted to be a mother. And that was something that she verbally always said. And going through the process of trying to preserve her fertility and then not being able to wrecked me. And also then seeing what her husband went through and what her mother went through. And it really made me think about, wow, we are really missing the mark on caring for young people with cancer. And that's where my journey in this space started.
Thank you so much for sharing all of that. And, it's so eye-opening when we witness friends or colleagues or family members go through a devastating diagnosis and you don't really understand all of the nuances that impact that person's life. And not just the patient, but then their loved ones, their family members, and their surroundings as well.
Yes.
And the very difficult decisions people have to make, not just about treatment, but about survivorship and their future. I think a lot of times when we're diagnosed with a breast cancer diagnosis, whether it's early stage or late stage, there's that flash of, oh gosh, I'm going to die, right? Like there's like, oh gosh, like
Yes.
what extent is this? Get the cancer out. Let's focus immediately, do everything we can to eradicate the cancer. Then I think as it settles in, we start to realize that life as I thought my future was going to be may no longer be what that perfect vision is, especially around family planning, or if you're living with a metastatic diagnosis, kind of truncating your life expectancy, feeling robbed of like opportunities to see your children grow up or graduate or get married, et cetera. And so I like that you talk about this like continuum of care, not
Yes.
just in the setting of recently diagnosed, but through survivorship. And I also love that your AYA extends beyond 40, even beyond 45, going up to 49, which I think is really helpful because so many of us in different pockets of life, whether you're in your 20s or 30s or 40s, are just navigating these complexities and totally
Correct.
coming to light right now.
The complexities, no matter your age in that time frame, or no matter what you're going through during that time frame, are very profound and they're very devastating. And so it's trying to find that balance of how do we prepare patients for what they may lose, not only medically, but also personally. And that age range, as everyone's always like, oh, that's so expensive, but so's life. And so's what
Yes.
you're going through in life. And you may go through something in your 20s that someone doesn't experience until they're 39 or in their 40s, and vice versa.
Exactly. If you think about that time of starting your career, exploring the world, trying new things, finding a partner, all of these things are happening. And then a diagnosis really halts you and, puts like the brakes on for you to really confront mortality, confront decision making, and really what your values are and what you're looking for. So let's jump right into, okay, a young patient just got diagnosed with breast cancer. My mind is swirling. I meet with and depending on the situation, you might be meeting with a surgeon first. You might be meeting with a medical oncologist first, et cetera, to have some of these conversations. When does fertility come up in the conversation?
So this is very nuanced. And I want to preface this portion of this whole conversation, I guess, is that I'm aware that access to a fertility specialist is not equitable or universally available across all institutions, and that these disparities can be particularly profound in for minoritized patients and further compounding their existing barriers to care. But looking at all of those pieces, and when you're thinking about fertility preservation or fertility in general or hormone health in breast cancer, the fertility risk is really not a one size fits all. It really depends on the treatment plan that is presented to the patient and what treatment modalities are being used. So, when I say treatment modalities, I'm thinking about not only that traditional cancer chemotherapy that you think about, but surgery, radiation, and other pieces that may be integrated into your care. And so some of these therapies have little to no impact on fertility, while others carry a high risk of harm. And that variability, combined with the important hormonal and genetic considerations, hormonal considerations like estrogen exposure and that suppression, is what really makes these conversations nuanced. And that is why I think this conversation between us is so important, not only for myself and healthcare providers and healthcare institutions, but also for organizations that support patients to help continue to guide people toward that right resource and points of care. And so,
Hmm.
the answer to your question after my
No.
little spew there is as early as it can be, right at diagnosis. It's really important to speak to a fertility specialist, whether that's a reproductive endocrinologist, a fertility navigator, or an oncologist. Even if they ultimately decide not to pursue preservation due to timing, preference, urgency of care, that consult still matters.
So providing that initial consult so that the patient has the choice and the options and that
Correct.
agency for themselves.
And I also am trying to have some shifts even in my own consultations of the value of that first visit is not only about preservation itself, it's understanding what treatment will mean for your body for the short term and for the long term, and understanding that full impact that treatment has on your body. It's very profound. And especially when we think about patients that are often faced with these choices. And one of the most consistent themes that I hear, and you probably hear, or even felt yourself, is that it's all about choice or the loss of choice. And there's something incredibly powerful about having choices, and it's incredibly painful when those choices are narrowed or removed entirely, whether by time, treatment, urgency, providers, circumstances. And so I try to balance knowledge is power and choice is power. And even when there's no real option to delay treatment or preserve fertility, there's still that value in knowing ahead of time what will happen to your body. And that awareness, in my opinion, can help restore some of that sense of grounding and preparation. I'm hoping I'm making sense.
So spot on. I love this conversation already. And so you're from like the 30,000-foot view of,
Yes.
how we confront not just a diagnosis, but giving the patient the choice and understanding who makes up their care team.
Yes.
And using myself as an example, I had very little exposure to even understanding cancer until my own diagnosis. And
Yes.
then to even understand who should be on that care team, whether it's a
Yes.
geneticist, a fertility specialist, a nutritionist, a mental health counselor, like all of these people, I was just like, I just thought it was a doctor. And I
So
didn't realize
much.
that I had like a Rolodex of like 10 people that were there to support me.
Correct.
I
And
wonder,
that's
go
really
ahead.
from a programming standpoint, because sometimes people don't want that in the beginning, and I understand that. But throughout the continuum of care, your mind may change and needs may
Yes.
change. And so knowing who's in your back pocket and in your toolbox is so important.
And I love what you said too, even if the options are narrow given the circumstances, that it's so much better to be proactive to have those conversations in
Yes,
advance before waking up from surgery or 6 months after chemotherapy, learning that you no longer have the option to conceive.
literally makes me like shudder.
Yes.
It's so profound and devastating. And if there's a way we can prevent that, I do want to acknowledge that some patients really aren't ready for that or aren't ready to have multiple conversations upon hearing all of the things that they've already heard. So I do want to hold space for that, but I do want to prevent that to those who do want that conversation. Um, Always want to preface that what I'm speaking about today, it is really important to have a provider looking at your chart and making the exact recommendation. So I'm going to talk a little bit, not broadly, but still focused, just because of that nuances that I'm not looking at your chart and know all of the itty bitty pieces. So, but when I'm looking at a patient from the outside looking in or through their chart and what I know, I'm looking at the what type of therapies they are getting. So when I'm looking at chemotherapy, for example, there are different buckets within chemotherapy and chemotherapy regimens that cause risk and don't cause risk. And there's a certain medication class or certain medication groups that are known to be heavy hitters to your reproductive organs or your eggs. And I'm looking for those medications in a person's treatment plan. And
Mm,
so when you know someone is getting systemic chemo, surgery, radiation, you're thinking about, oh, like they're getting all of these different things coming at them, but what type of drug are they actually getting? And then looking at the cumulative dosing of that drug. So not only it's a one-time drug thing, but I'm looking at the whole continuum and seeing, okay, what will that impact be? And kind of stratifying people with the partnership of oncologists, of course, low, medium, high. And so when we're looking at triple negative and we're looking at diagnoses that contain higher treatment plans, I'm always thinking about fertility and that hormone health as well. And my biggest piece there would be having the conversation, number one, and approaching it as, for many patients, treatment, like I said, is going to look different. But I always want to emphasize that we have a couple choices and we may not have any choices. And with this topic, for example, is that it may be that cumulative dose that is very destructive, or it may be in that time while you're on that chemotherapy, you shouldn't pursue pregnancy or your hormone health is going to be impacted while you're on it. So that differentiation, I think, is also extremely important.
mhm.
And that's something that I think not a lot of people think about. And so in consulting patients like this, I just wanted to say all to note all of that.
And maybe you're best taking this, as you were mentioning, like the drug classes, less so about the type of diagnosis, but how you're looking at the entire regimen that the patient is going to be exposed to. And even within that regiment too, I know we're always talking about the standard of care and we're also like
Yeah.
advising based on guidelines. And so again, when we think about choices and even in our work that we do at survivingbreastcancer.org, it's not uncommon for someone to say, what if I refuse radiation or what if I refuse chemotherapy as well? And so understanding the risk just in general as you're having some of these difficult conversations, understanding the values of where the patient are coming from, what's most important to them, and then understanding curative intent or, how are we trying to preserve recurrence?
And at its core, fertility preservation is about maintaining options. I like those options to be available regardless of the conversation. I kind of take metastatic disease out of the picture. Regardless if when I'm looking at you, if you're low risk, high risk, metastatic, I'm talking to you. And maintaining those options, it's not necessarily in that moment deciding, okay, today is what my whole future is going to look like. It's keeping that space for your future to evolve. And so that's why I still hold these conversations. And people are probably getting frustrated with like, oh no, I want to know exactly like triple negative, what to do. And but
Yes,
this
we're,
is
we're
what
holding on to like as much information as we can because it's so chaotic to be
yes.
diagnosed.
Yes. And yes, that puts you in specific buckets, but even if you weren't in that bucket, people change their minds. Perspectives really shift after diagnosis, during treatment, after treatment, life experience, before, after, during. And what feels important at that certain moment, in that moment of time, like we discussed earlier, like, oh, I just want to survive, I just want to survive, I just want to survive. But having that option that you might in one moment feel different, and that flexibility really matters to patients, and it goes a really long way.
And it's okay to change your mind too. I think giving someone the freedom to say, you know what, we understand you made this choice at that time, and it's okay to evolve. I love that you position it that way.
Absolutely. And there are many ways to build a family. And some individuals may never use what they preserved if they choose to preserve. They may choose not to pursue a biological child. They may have some ovarian function afterwards, which I can talk about a little bit as well, that they weren't expecting, or just simply change their minds over time. And those paths and holding space for those paths to evolve is valid.
Yes, absolutely. I'd love to dive into some of the nitty gritty in terms of trying to preserve fertility function. I know in my case, I had to make a decision very quickly. I was like, I literally, I think, I don't mean to sound like flippant, but I like turned to my husband. I was like, are you cool without kids? Like, let's not do it. Let's start the chemotherapy because there was kind of time pressure. And my headspace at the time was like, let's just eradicate the cancer and do everything we can most aggressively. I believe I was given some sort of shot. I'm blanking on the name right now. Yes, Lupron. Yes, exactly. Now, can we talk? I mean, so what was the Lupron doing? And it was like trying to
Yeah.
preserve the
This
ovaries
is
while I was on chemo. So yes.
this is a really great question. So, tiny bit of background for a split hot second. For many patients, like I said, they may have medications that place them in that temporary or sometimes permanent menopausal state. So, like the Lupron, like you were talking about. And that has wide range of implications, not only beyond fertility. And so when you're looking at a shot that turns your ovary off, puts it to sleep, as I like to say, you also need to consider what type of side effects am I going to feel during that? And what are some ways to combat that? And so when we're looking at patients who are getting Lupron, I do want to say that it's still primary. There are some studies that really support that, smaller studies that support that it is a fertility preservation mechanism, but there's some literature that you'll see that it's not a fertility preservation option. And so it's important to note that sometimes when you're on the internet and when you're in the medical institution, you might hear
Mm.
various opinions, even among team members, regarding what that medication usage is. Many times, as you may know from even your own experience, it's coded as menstrual suppression.
Yes.
So, hormone health is just essential for patients assigned female at birth. And so, when we're looking at the Lupron shot, I like to think about the ovary and how it functions as a light bulb. Hang with me. So when you are young or even in your 30s, even in your 40s, your light bulb shines nice and bright. And as you get older or as you experience, naturally getting older, that light bulb starts to dim. And before it completely dims, you know how like when you have a light bulb that's about to go out, it flickers on, flickers off, flickers on, flickers off. That's kind of what some people experience after therapy with the impact of treatment. But with Lupron, we're not really trying to diminish the light. We're just trying to turn it off for a very short amount of time while you're on therapy. Mechanisms of action can make it completely turn off. But with Lupron, it wakes back up slowly. So the dimmer just goes up, up, up until it's shiny. Now, how bright it'll shine might vary from when you first started treatment and it was bright as can be to, okay, after treatment, it's slightly dimmed, the dimming that I like when I have a headache. And so that hormone health, like I said, is so important, not only for building family, but while you're on this, thinking about your bone health, your cardiovascular health, your mental health. And so for some patients, they may fall into this category where that Lupron shot or that hormonal piece shutting off may never go away and it can't be replaced over time. But it's important to know that up front instead of like no surprises later. But also at the same time, there are some individuals, even while you're on the Lupron, that hormone therapy in certain situations, this is one on one and speaking with your doctor about it,
Yes.
can safely be replaced while you are on therapy to help manage some of those side effects that you get when that ovary is turned off. So, hot flashes, night sweats, and other treated related symptoms. And so, I think that's where I go back to why this seeing a specialist or talking about your fertility should not be the single moment in time. It should be throughout your entire continuum of care because of nuances like this. It's not just the beginning, like, okay, I'm turning off my ovary. It's you're gonna still feel the impact of that ovary turning off. And can it ever turn back on? Or can you ever safely add back? And so there's these nuances that people just don't know about that people should know about.
One of the things that scared me is that I love your analogy here. That was so clear. So thank you for sharing that.
I'll get back to
As
that. I'll get back to that.
good.
There's
Okay, excellent.
a little more to that. Yeah.
But as the ovaries are turning back on, if you will, for again using my case as someone with ER positive, hormonal positive breast cancer, I started to experience symptoms of the ovaries reawakening, which made me very happy because I was like, "Ooh, look at this! Maybe I'm menstruating again. Maybe the ovaries are healthy again." And then at the same time, I was like, "Oh gosh, I need to call my oncologist right away because I don't think I'm supposed to be menstruating. What is going on?" And so I guess the question here is like balancing
Yes.
the whole experience, I guess, when you know that you're not supposed to have your hormones aren't supposed to be in balance. We're trying to like shut these off. We're also on aromatase inhibitors or tamoxifen or other things that are kind of keeping the cancer at bay while also trying to say, gosh, my hormones are a mess. What is going on?
Yes. And so going back to my light bulb analogy is that some individuals who are on those therapies or situations that you mentioned that when the ovary starts to fail, for example, or hey, I'm on my way out, I'm going to turn off. It likes to flicker. So it'll flicker on and you'll feel some hormone and then it'll flicker off and then it'll flicker on and off. And when it flickers on, you never know how long is that flicker on going to be or how close it's going to be, or is it going to be just with open and then shut, or open, shut, open, shut, open, shut. And so sometimes you see some individuals, not even individuals who've never had cancer care, who are going into menopause. Surprise, baby, because of that flicker on, flicker off. Now, not certainly in these nuances where you're on those medications that, like you mentioned, typically don't happen. But that's why you can see scenarios like this in cancer and after cancer is because of that flickering
Okay.
before it shuts off. And so it is alarming to be like, my hormones back on. But it is good to know this is part of the ovary starting to turn off. And sometimes, in some circumstances, there might need to be some adjustments to keep it off
Mm,
versus letting it flicker, if that makes any sense. And it's also important to note that the hormone itself, when it's flickering, working with a specialist to say, okay, it's actually flickered on for a while, checking with the hormone level because that also matters too. When you have an ovary that's not working well, your hormones aren't typically as surged as when your light bulb is really bright, if that makes any sense.
absolutely. Absolutely. Well, thank you for explaining all of this and kind of going into, I mean, the light bulb, I want to say like we're going into the science, but at the same time, really understanding our function and how the ovaries work.
Yes, yes. And I think that's really important to think about and to know and maybe to anticipate afterwards, or even an education point of like, hey, if this happens, then you call X, Y, and Z. Where in your situation, you're like, what do I do?
I freaked out. And we'll definitely
Yeah,
talk about that at
absolutely.
some point.
Absolutely. As anyone and should be aware of that. You should be in tune to that. Yes.
So when we talk about fertility preservation, I know we've been referencing that term.
Yes.
Can you talk and maybe just like define that for us? Like, what does that actually mean?
Yeah. So fertility preservation, I'm thinking about the individual specific tissue. So eggs or ovarian tissue that would be preserved for them to have a biological child in the future. This to maintain that genetic piece to them so that that is maintained. What gets nuanced there is like, which one should I choose and why the ovary in an adult or why eggs in someone? And that's very individualized based upon timing. Some individuals, when they are older and have to, or prepubertal, and they have to get treatment right away, and there's no other option, they don't have 2 weeks, and they can safely undergo a procedure to take the ovary out to preserve that for the future, that can be done. Most of the time, sometimes when we see cancer patients, sometimes they're like, hey, I'm starting with surgery first. I have 6 weeks until I have surgery. You may have that 2 to 3 week time frame to pursue fertility preservation and pursue eggs. Because for me, when I'm thinking about options, I'm also thinking about how they can be utilized in the future. And eggs, as we know, and embryos, as we know, have been utilized in IVF and fertility treatment for a long time. Now, does that guarantee a pregnancy in the future? No, but it's more likely, more of a slam dunk that you'll be able to have a pregnancy in the future. Whereas when we think about the ovary, it depends on prepubertal, which I'm not going to get into, or pubertal. Thinking about individuals who are menstruating, they can remove that ovary, and depending on the disease that they have, sometimes pieces of that ovary, when they take that ovary out, they slice it into thin sheets, kind of like it's probably a bad example, like a deli slice. And people can have that tissue reimplanted afterwards if it's safe to do, if it's an option to do. And so sometimes individuals choose that route if that is an option that is safe to pursue at diagnosis.
It's a lot to consider, like
It's
all the options.
so much to consider. And then you
Like I'm overwhelmed and I'm not even in this stage
Yeah.
right now.
And then you also have individuals who are like, hey, I have this deeply personal genetic consideration. And for some patients, that really adds a whole other layer of complexity, particularly when you're considering a hereditary cancer gene that can be passed on. And so some individuals like to pursue that regardless of their fertility risk because they want to be able to do that pre-implantation genetic testing before treatment. And they want the best eggs that they could have possible. That way, the passing on of the gene is considered for their future and they go through IVF, not really needing to from treatment, but because of that choice. And so others just may consider it as, like I said, as proactive, I think, pre-survivorship or even during cancer and just in that effort to avoid passing that gene. And so these are, as I mentioned this, I want to acknowledge too that this is deeply personal and it's really shaped by values, time, identity, future hopes, not just the medical risk. And people approach it in so many different ways.
Amazing. And I'm glad you're bringing all of those complexities to the conversation because, yes, it's not just the medical team, but it's all of these other external factors that help shape those decisions that can evolve over time. And just reframing this back to those ideas of giving options to people
Yes.
is really at the crux, is what I'm hearing.
Yes, it's at the crux. And caring for breast cancer patients has really opened my eyes to just how deeply devastating these nuances are of fertility preservation. Like you're like, wow, this is a lot. It is. It is. And the gaps that remain in how we prepare patients for what they may lose or what they might lose personally, medically. And so it kind of goes back to that notion as well of like
Yeah.
what can we not lose?
Yeah. And I think this is a segue into understanding some of the grief that comes with a diagnosis and identity when with something as specific as breast cancer, when we're going through breast amputation, when we are changing the physical, that yes, we're trying to keep our chances open for life and survival and everything. But at the same time, loss of breast, loss of female identity to some degree, then to having these conversations about like motherhood are also very deeply like rooted in identity, whether you want to be a mom or not, but just understanding like your female body parts and the
Yes.
idea of femininity. So I think there's a lot of grief that can bubble up in the moment and then also even years afterwards when you realize the loss that potentially happened. So we talked a little bit about the treatment. Can we talk a little bit about the when you speak about like the continuum of breast cancer and people who are on hormonal therapies for 5 to 10 years and are considering family planning at that phase? How do we have those conversations and when is there in consultations with their doctors and their oncologists and working with people like yourself decide when is a healthy time to stop some of these medications to take kind of like a tamoxifen break or an AI
Yes.
break
Yes. Yeah.
to
A
start
lot of
family
opportunity.
planning?
That is a golden question that is impacted by a various layers. But my most important piece I was actually asked this recently is really working with your oncologist, especially when you're in that off therapy phase of saying, hey, I really want to get to this point. How can I get to this point and when? And what should I be seeing, asking, and doing to get to that point? And also asking that provider, hey, can you work with my fertility specialist on helping me get there? I think that is profoundly important for the oncologist to know, which I know it's sometimes hard to talk to your oncologist about certain things. So, anyone in your care team, I should say, social work, nurse care manager, physician, should really be in tune to those questions and those like hopes and dreams. But sometimes their blinders are up. Cancer, 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 maintaining, 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 and they may not know that is the goal.
Mhm.
And so I emphasize as soon as you have that tinkling, or if you have that tinkling even in the beginning, I would say, hey, this is my goal. How do I get there? And I know that that's so blanketed, but it's so variable depending on the patient. But that's my nugget on that one.
I love that. So having these conversations throughout your experience, talking to, and I love the options that maybe if you don't have that close relationship with your oncologist, maybe it is the social worker, maybe it is like the nurse practitioner that you see in every like 3 months when you're checking in.
Or an external partner like you, or a community or family member that might be a little bit better at advocating for that. Because that advocating for that is nuanced because it leaves a shield down a vulnerability of like, hey, I might invite something to come back in and I don't want to do
Hmm.
that. But I
Right.
also, you don't want to live in I hate to say fear, but it can also be so consuming that you should really have every knowledge option conversation supporting that, because that, like I said, that knowledge is
Yeah,
power, and kind of being able to anticipate, okay, I'm only going to have X amount of time. How can I make that the most worthwhile and who can get me there?
exactly. Exactly.
You brought up a something that I really have thought about a lot recently and even had a conversation with other partners about this previously, is that sense of body betrayal and identity. I really underestimated in breast specifically that there's this profound sense of body betrayal, not only from the cancer itself and not only pre treatment, but during and after treatment. And this is so amplified by, like you said, the changes in breasts themselves, or and for an area that for many, though not all, is deeply tied to sexuality, identity, confidence, self-image. And I having that compounding factor of I have all of this going on with my body betrayal from my breast, from my cancer, but also now being having infertility. And it just is coming at all angles. And I just never really I completely underestimated that as a provider. And so that is something that I have really made note of. And when I'm talking to people, is holding space for that and holding space for people to feel that.
So true. So true. And I've heard the gamut of stories as well where it has strengthened relationships with a partner because you can or cannot conceive. And it's also broken relationships with partners because, I didn't sign up for this type of thing. Right. And that can be also very devastating to navigate marriage, divorce, dating, how to have these conversations with a new partner, when to bring
Yes.
it up.
Yes, because it's like you have the monster under your bed of recurrence or all of those dynamics. But and then you also have the dynamic of I have to share this really vulnerable, sometimes for some people horrific experience with people, a person that I'm starting to get to know and that could really change their mind about me and the relationship with me. And that is so devastating and it's so hard to balance.
In the scenario where someone is looking to conceive and have a baby with their own genetics and everything that we were talking about, and we get to that win and there's success stories. There's also the opposite of that where it's not guaranteed. Can you talk to
Yes.
me about what are those factors that would make something, successful versus not successful?
So, various things that I have seen in my own practice that have impacted it is, say you were able to do an egg harvest, and however, though, your response to treatment wasn't the greatest from those hormonal medications, and you retrieved 4 eggs, 5 eggs, or a smaller amount of eggs or embryos. First, I'm going to start with eggs. With eggs, then you're like, okay, I'm I have something. And then when you go to make it an embryo, that also isn't a guarantee. So then you sometimes narrow your choices to, I have 2 embryos, and that's still not a guarantee. And so I see a lot of those factors of, I have my eggs and now I'm putting them in with trying to make them an embryo, either through sperm donation or partner, and my embryo option is limited. And then my hormonal function is so low that, do I continue to do the hormonal medications and try to get more eggs, even though that's not a guarantee? It's so complicated. Going into any type of fertility treatment to get pregnant comes with its own risks in itself. We hear about people who have undergone cycles and cycles and cycles of IVF and egg retrievals that have unexplained infertility, or that have other fertility considerations that it just didn't work out. And so it's really challenging to know. And this is why talking about all family building options, even as providers, as community partners, is so important, because it's just not guaranteed what's gonna bring you to parenthood. And that is really grappling it's grappling to think about and to deal with after you've been through so much. You're like, I need a win.
Yeah,
um,
exactly.
it's really hard. Other scenarios that I have seen is, unfortunately, individuals who were married or in a partnership when they were first diagnosed, and then they no longer are together. So they have these eggs, and they pursue a sperm donor, and kind of going through that process, kind of with the same implications of, when you put the egg in, it might not implant. And so I've seen that a few times as well.
Yeah, lots of variation and variables to consider, not on top of just navigating a diagnosis, advocating life as a young adult being diagnosed with cancer, and then understanding what the future of life can look like. I love that you're offering different family planning options too, not
Yes.
just biological, but other things.
Yeah.
And I'll just like throw myself back in as the example where, even though I said earlier, William and I talk about this, we like joke, I like literally turned to him, I'm like, are you cool without kids? But I still went and ended up having Lupron just in case I
Yeah.
changed my mind.
Yes.
And then I was
Absolutely.
on Lupron plus an aromatase inhibitor, and you're talking about some of these side effects. I was like, for 8 years, I was like enduring the hot flashes and the mood swings and the weight gain and all of these things. And so, it's again keeping options alive, even though in my head I was, it was always on the back burner, but then having the choice to decide, do I want kids or not kids, versus letting life make that decision for me.
Yeah. And that's, I think, too, the hormonal side effects. As gonna insert myself for a split second, as someone who is going through that as a 36-year-old, it is brutal. And it has been, as someone who is very medically complex, it has been one of the hardest things medically I've ever gone through. And so I don't think, as provider society, even what you know, can ever prepare you for that. It is so debilitating at times. And it's really hard.
Thank you for sharing that. Are there questions that I haven't asked that you want to let our listeners know?
Like I said before, knowledge is power, knowledge is power. And I think sometimes pursuing that knowledge can be hard, because you don't want that door to be shut, and you don't want to hear that that door is shut. But really empower, motivate, root for having the conversation. If it's something that you are like, I can't talk to my oncologist about this, or I can't talk to my surgeon about this, I'm a little intimidated, nurse coordinator, social worker, anyone that can connect you instead of having the conversation with the provider, I think is really important to know, because some people think, oh, the referrals can only be placed by a physician. Not true. Most providers can social workers and nurse coordinators can place referral orders for people to be able to get scheduled. I think or if they can't place them, they can tell or send it to one of their providers that can sign orders behind the scenes on the back end. I think it's really important when talking to providers and clearly trying to get a sense of what is my timeline?
Mm,
What is my timeline? Or what is my approach to treatment? And what is the space between surgery, radiation, chemo? Because maybe you have surgery first, and depending on when other things get looped in, is that going to be a time that you can do it after surgery or even before surgery? Because sometimes I think having a little bit more time or trying to create more time, people don't realize, oh, can I try to shuffle things? And some people might not be able to. It might be like, no, it's this, and that. And that's what you need to do to get the cancer ultimately gone. But I think sometimes there is space for people to negotiate time
yes.
or to really see, hey, is 2 weeks after X, Y, and Z, is that an option? Just to give more time to sit with all of the information that you've received.
Hmm.
Other nugget, and this is kind of more of a blanket statement of even just myself. And so, as I've grown in this work, I'm trying to be very intentional about shifting from building programs, research, patient education, collaborations, and systems for patients to not for patients, but with patients. And so, the patient voice is so incredibly important. And I never want people to forget that, and I want to encourage people to, hey, let's do this with the healthcare institution or with the external partner or with instead of for. I know for is
Hmm.
also super important. And
Yes.
sometimes you do things for before you even know what the implications are. But I think being part of a healthcare advisory group, being able to share your story, and I say that with the utmost respect that sometimes people can't talk about it and that is not healthy for them. So I'm saying this within your boundaries of your own self health, but being part of the team in some way, shape, or form, even through mentorship of another patient or through your institution or through a external partner, um, writing
Yes.
workshops, anything, just trying to be with instead of for.
I love that. Absolutely. And I think that's at the crux of even if it's for, it's always with the greatest intention. But if we're not doing it in partnership or in collaboration, we could just be so much better. I really agree. And we have so many committees at survivingbreastcancer.org. And I honestly have to say, like, the more minds and eyes and ideas that are coming to the
Yes.
table, the better the end
Yes.
product is going to be. And I've seen that in my work, and it is so profound. I love it.
So profound. And I thank you for all you're doing for the community because I know that sometimes what's offered in the walls of your hospital aren't enough, and it shouldn't always be enough. And institutions, like I said, when I'm programming, I'm really thinking about, hey, this partner does this really well. Why reinvent the wheel? Let's bring them in throughout the continuum, regardless of where it happens to happen, and being open with multiple options from multiple different sources.
Yes. If I was not being treated at X, Y, and Z hospital, I did not have access to those doctors or those resources. And as you mentioned earlier, if we look at the majority of people in the United States specifically who don't have access to academic centers, cancer institutes, et cetera, how do they find the fertility specialist? Or even I want to say, bringing up, and we haven't really talked about insurance and finances, but are there telehealth visits? Are there telehealth options that people can find if their clinic doesn't offer it?
This is an incredible question. And something that is really important is that I know I'm extremely biased when I say this. So I'm going to preface this that I really do feel that having experts around you that are experts in young onset breast, AYA, young people with cancer care is incredibly important. Now, is it realistic? I'm going to throw myself as an example for everyone to come talk to me in the country. No, no one.
After this podcast, they will want to. I will just let you know. Everyone's like, "Where's Kara?"
It's not feasible. Really leveraging who you can talk to and when. So I've had a couple scenarios where We have a patient that is getting treated. They have to drive 3+ hours to get to our main location, and they're able to get it at one of our satellite locations that's a little bit closer. Because if you think about it, most pharmacies have the ability to get chemotherapy or chemo to them. Most, not all. Another layer to this is I have another patient that is a little bit farther away, and they did everything virtually. They talked to the RAI physician, and then they talked to an oncologist, and the oncologist gave a treatment plan, and they gave it to their oncologist at home, and they now work together on treating the patient. I do want to say that I do know that telehealth has its quirks, but it can be a very powerful tool in trying to reach another provider. Now, some people may not even be able to do it that way. And I think that's when we have our external partners and free education and conversations like this that can help shape and connect patients to where they need to go is crucial. Crucial. The other layer to it is with insurance. That is a bear in itself. And as we know, many fertility treatments aren't available, and some states have mandates and some don't. And when you have different types of insurance, you might get one piece, but not the other piece. And so, my biggest piece of advice is when looking at, for example, certain fertility labs, asking your oncologist, your nurse practitioner to say, hey, can we place these with you under oncology so that it's linked to oncology so that maybe it gets covered that way? Try to finagle some things there. Doesn't always work, but something that you could consider. um,
Yes.
Other pieces that you could consider is asking your organization, hey, do you have internal funding to help cover fertility preservation services? Or do you know any of external partners that cover fertility services? I'm very biased. I'm on the advisory board for Worth the Wait charity. We support all family building options. And so, always wanting to make sure that people have other resources outside of the hospital. But dealing with insurance is incredibly frustrating and it's incredibly isolating, especially when it's not accessible to everyone. And trying to break down these barriers, even through legislation, is so challenging, but we're chipping away at it. And I hope one day that it's covered by all insurances as it should. Because as we know, this is also a quality of life factor in
Completely.
patients after treatment. And I also think that, yes, you consent to cancer treatment, but you don't consent to being infertile. And that's an impossible thing to ask someone. I'm going to sign this cancer treatment consent, but I don't consent to that. And that is an ethical, in my opinion, challenge.
Kara, thank you so much for this conversation.
I love talking about this, if you can't tell.
I love it. It's amazing. It's so empowering.
Um,
And I really hope our listeners are like sitting on the edge of their seats, feeling empowered and all of the emotions that, like, I think even just in this hour conversation, the highs and the lows, the joy and the sorrow
yes,
that can come
yes.
with talking about this topic. So I appreciate your time and your expertise and your passion for all of this. I definitely am going to have you back so we can continue
Please.
this.
I really appreciate the platform because, like I said, not everyone has access to this information. And I will die on the hill trying to get people, as many people, to hear this information as possible. So, thank you for making that happen.